Excuse me, sir. Here's a venous blood gas of a patient with suspected decay.
Yeah. What are the vitals of the patient, doc?
Her BP is 60/40 and we are resuscitating her.
Yes, I thought so. Patient's lactate was very high, suggesting that the patient is in shock and circulatory failure. Didn't you know, by the way, that you cannot take a VBG in a patient who's in shock?
Is it so, sir? I didn't really know about it. Can you explain about it?
First of all, let me tell you that ABG is the gold standard. VBG is only going to act as a substitute in certain situations. And what are the parameters that you're going to look out in the ABG? You're going to look at the PaO2, the PaCO2, the arterial pH, arterial bicarbonate, and the base excess. What are the parameters you're going to look out in the VBG, that is venous blood gas? You're going to look at the PVO2, that is venous oxygen, the PVCO2, that is venous carbon dioxide, the venous pH, venous bicarbonate, and of course the base excess as well. In these 5 parameters, there is a good agreement with all the parameters as that of the ABG except for the oxygen. The PVO2 and the oxygen saturation of the veins does not correlate with the PaO2. So if you want to assess the oxygenation status, your VBG is not going to be a good alternative. But if you want to look at for the other parameters, VBG is a good alternative to that of ABG in certain situations, but with certain adjustments as well.
Adjustment, sir? Can you explain about it?
I cannot teach everything in a single instance. For that, you have to wait for the part 2. But before going to the part 2, you along with the viewer should be able to answer this question. What is the most common acid-base abnormality that you're going to see in a patient with diabetic ketoacidosis?